All right, let's dive straight into this high-yield clinical explainer on bladder cancer. Now, whether you're a practicing doctor who just needs a quick, sharp refresher, or you're deep in prep for exams like the MRCGP, AKT, this is all about giving you the essential, need-to-know info on staging, management, and prognosis. And we're going to start with the single most important number, over 90%. That's how many bladder cancers are urothelial carcinomas, which you might also know as transitional cell carcinomas. This one fact really frames everything we're about to discuss, from the causes all the way to the treatment. So here's how we're going to break it all down. We'll start with a general overview and the key risk factors. Then we'll get into the pathology, what these cancers actually look like. After that, we'll talk about how patients present and how we diagnose them. Then comes the really crucial part, TNM staging. We'll explore how treatment is decided by stage, and finally, we'll wrap up with prognosis and the main takeaways. Okay, let's jump into section 1, overview and risk factors. This is all about who gets bladder cancer and, more importantly, why. So what does the typical patient profile look like? Well, it's the second most common urological cancer, and it's much more common in males. You're usually looking at an age range of about 50 to 80. Now, the single biggest modifiable risk factor, and this is a huge one for exams, is smoking. It jacks up the risk by 2 to 5 times. And it makes sense, right? Carcinogens from the smoke get filtered by the kidneys and then sit and concentrate in the urine, giving them prolonged direct contact with the bladder lining. You also have to think about industrial exposures, like hydrocarbons, and in certain parts of the world, chronic inflammation from things like schistosomiasis, which is classically tied to the squamous cell type. Right, on to section 2. Now we're going to look under the microscope at the histology and, really critically, how the tumor's physical shape and growth pattern can totally change the patient's prognosis. And this chart just drives home that point we started with. As you can see, it's overwhelmingly urothelial carcinoma. I mean, it's basically the whole pie chart. Squamous cell and adenocarcinoma are much, much rarer, which is why clinically we're almost always focused on that urothelial type. So within that urothelial type, there's a really important split in how they grow. About 70% are papillary. You can picture these like little fronds or finger-like things growing into the bladder cavity. Because they grow inwards, they tend to stay superficial, and that means a better prognosis. On the other hand, you have the solid or mixed tumors. These are flatter, and they tend to grow down into the bladder wall. That makes them way more likely to invade locally, they're usually a higher grade, and yeah, they carry a much worse prognosis. This difference is fundamental. Okay, section 3. How are these patients going to present to you, and what's the definitive diagnostic pathway we need to follow? Let's cover the red flags to look for and the exact investigations we use to lock in the diagnosis. This is it. This is the single most important clinical sign to burn into your memory. In 85% of patients, it's visible blood in the urine with no pain. Anytime you see that, once you've ruled out a simple infection, it is a massive red flag that needs urgent investigation. It's the #1 sign, and catching it early is everything. The workup is pretty logical. For the actual tissue diagnosis, the gold standard is a cystoscopy, sticking a flexible camera into the bladder and taking a biopsy. Often, this is done as a TURBT, or transurethral resection of bladder tumor, where the surgeon just removes the whole visible lesion at the same time. Once you have the diagnosis, you have to stage it. A pelvic MRI is the best for seeing how deep it's gone into the bladder wall, while a CT scan is what we use to look for any distant spread. And if we're not sure about the lymph nodes, a PET CT might be considered. Which brings us to section 4, TNM staging. You absolutely have to understand this framework because every single management decision flows from it. We're going to break down what T, N, and M mean and how we use them to classify the cancer. So what is TNM? You can think of it as the universal language of oncology. It's a system that gives us a standardized way to describe the cancer spread. We look at the primary tumor size and depth, that's the T. We check for spread to nearby lymph nodes, that's the N. And we look for distant metastasis, that's the M. Now, this slide shows the single most important dividing line in all of bladder cancer. Has the tumor invaded the muscle wall, the muscularis copria? If it's still just in the inner layers, we call that a TA or T1, and it's non-muscle invasive bladder cancer, or NMIBC. But the second it hits that muscle layer at stage T2 or higher, it becomes muscle invasive bladder cancer, or MIBC. And at that point, the treatment, the prognosis, everything changes. And here's the detail in the table. See, TA and T1 are non-muscle invasive. But that critical jump is to T2. That's when it gets into the muscularis propria, and that is the definition of muscle invasive disease. T3 means it's gone all the way through the bladder wall into the fat around it, and T4 means it's now invading nearby organs. Then, of course, the N and M stages tell us about any spread to lymph nodes or other parts of the body. So, we have the stage. How does that turn into a treatment plan? Let's get into Section 5 and see how the therapy is tied directly to that crucial question of muscle invasion. We'll look at the different options for both NMIBC and MIBC. It's really a two-track system. For the non-muscle invasive stuff, the treatment is local. You do a TURBT to scrape out the tumor, and for higher risk cases, you might follow that up with intravesical chemo. That's where we put the chemotherapy agent right into the bladder to kind of wash over the lining and kill off any stray cells. But for muscle invasive disease, T2 or higher, you have to get radical. And that means one of two things: either a radical cystectomy, surgically removing the entire bladder, or radical radiotherapy. Which brings us to our final section, prognosis and the key takeaways. Let's look at the survival numbers based on the stage and wrap up with the most important clinical pearls you need to remember from all of this. This bar chart tells a really powerful story. Look at the bar on the left for a T1 tumor, 90% 5-year survival. That's pretty good. Now look what happens at T2. The moment it becomes muscle invasive, boom, survival drops to 60%. At T3, it's down to 35%. And for T4 disease, it can be as low as 10%. This just perfectly illustrates why that distinction between non-muscle and muscle invasive is so incredibly critical. And this explains exactly why that survival rate falls off a cliff. Once the tumor punches through the bladder wall at stage T3, it gets access to all the plumbing, the lymphatics and blood vessels. Suddenly, the risk that it has already spread to the lymph nodes or somewhere else jumps to 30% or even higher. The local invasion is a direct gateway to systemic disease. So we'll end with this question to really hammer home our main point. Given how dramatically the prognosis changes with stage, early detection is absolutely everything. This brings us full circle. So what are the key takeaways? First, over 90% of cases are urothelial carcinomas, often linked to smoking. Second, the single most important factor that dictates everything is that line in the sand between non-muscle and muscle-invasive disease. And third, because of that, our number one job is to find it early, which means we must always investigate that number one symptom, painless macroscopic hematuria.